It is sometimes difficult or impossible to obtain embryos from superovulated cows. In those animals, in vitro fertilization can bypass this problem. In vitro fertilization also holds promise for research and for the production of embryos when oocytes are not available. For example, the production of embryos from stem cells may even be possible. Unfortunately, serious complications can arise when either IVF or cloning is used. These problems include early embryonic death, abortion, excessive fetal size, hydrops of the fetal membranes, skeletal fractures, and a high incidence of neonatal death and increased death rate in the early years of life. Those problems are more accentuated in cloning than IVF, but even in IVF, problems such as hydrops occur 20 to 25 times more frequently than in natural pregnancies. In this case, in vitro fertilization had been done only after repeated attempts to collect embryos had failed. The heifer was presented about 224 days after conception. At that time she showed remarkable edema of the ventral abdomen and udder, and the farmer was concerned that she may be aborting. Here you can see pitting edema on her udder, and in the video, fluctuation of subcutaneous edema on the ventral abdomen. The first ultrasound image we obtained showed very echogenic, turbid amniotic fluid, and above it the less echogenic allantoic fluid. At the top right-hand side, a small placentome was visible. As you'll see later, our initial impression of the size and the number of placentomes was somewhat misleading, because although it was obvious that there were relatively few placentomes, they all appeared to be fairly consistent in size and all fairly small. Looking at this ultrasound image of the amniotic membrane, one can see how thick it is, a sign of substantial edema and an indication of things to come. Although we saw relatively few placentomes transrectally, transabdominal scanning seemed to suggest that there were many more placentomes per unit area than we had originally suspected. Also notice how echogenic these placentomes were. Perhaps that was a reflection of the caruncular fibrosis that has been described in similar cases. Now, in this image, one should take special notice of the amniotic edema again, and the striking amount of ascites in the abdomen of the fetus. Interestingly, the abomasum was a consistent landmark during ultrasonography, as was the fetal liver, which appeared to be very echodense. During the first couple of days after this heifer arrived at our hospital, fetal movement was consistent, obvious, and rapid. At the same time, it was relatively easy to locate the fetal heart and to determine that it was beating at a normal rate for a fetus of this age, about 115 beats per minute. During the 4 days that we observed her in hospital, this heifer gained weight consistently and rapidly, as shown on this graph, and towards the end of that time, her abdomen had increased in size so much that she experienced difficulty in entering a chute. On the 3rd day after admission, repeated transabdominal examinations confirmed that the fetal heartbeat was no longer present, and that fetal movement had ceased as well. Despite the fact that a progesterone-releasing intravaginal device, or PRID, had been placed in her vagina on the 1st day, the heifer began to abort on day 4. The PRID was removed immediately, and abortion was allowed to proceed. Now, because of the relatively low value of this heifer and potential complications that could arise from hydrops, the owner elected to have her euthanized. At post-mortem, the carcass and all organs were weighed carefully so that the amount of fluid in the allantois could be determined accurately. Once the uterus had been laid out on the table, its massive size was immediately evident. Although this fetus was only 7 months old, the appearance of the uterus was consistent with that of a large pregnancy at term. The uterus was opened carefully so as to preserve allantoic fluid, some of which had been lost between the onset of abortion and the time of euthanasia. With careful weighing, before the postmortem had begun, we determined that the lost volume was approximately 66 liters. On initial entry into the uterus, it was surprising to see a large volume of fibrin between the surface of the coriolantois and the endometrium. Now, to our knowledge, that feature had not been described before. The most striking feature upon removing the fetus and its membranes from the uterus was the low number of placentomes on the coriolantois. The usual number of placentomes in a bovine pregnancy is somewhere between the range of 75 and 120. In this pregnancy we counted only 59 placentomes, probably significantly fewer than normal. There was substantial edema in the coriolantois, evident here by pitting edema that left the coriolantois virtually transparent at the site of pressure. We obtained a sample of the allantoic fluid and found its sodium concentration to be approximately 2.5 times the normal concentration for pregnancies close to this duration. Phosphorus concentrations were approximately 3 times higher than normal. It has been suggested that this reflects an inability of the fetal kidneys to reabsorb sodium and phosphorus in the proximal convoluted tubules. With the osmotic potential of sodium, this is thought to be a principal factor in the development of Hydrops allantois. We also sampled the amniotic fluid and found that it contained high concentrations of phosphorus and creatinine. Here again, those electrolytes speak to some form of kidney malfunction. In this image, one can also appreciate the substantial amount of edema in the amniotic membrane. The amniotic edema was also obvious on closer examination, where the edema appeared to have dissected tissue layers, causing them to peel apart easily. We drained the amniotic fluid carefully, eliminating fluid as completely as possible from around the fetus. By weighing the fluid, we determined its approximate volume. And as you can see from this bar graph, this fetus had already accumulated 25 liters of amniotic fluid at an age of only 7 months. This was far greater than the range of 2 to 8 liters normally formed by the end of pregnancy. After obtaining the volume of amniotic fluid, we subtracted it, together with the weight of the carcass, uterus, and fetal membranes, from the initial weight of the heifer at postmortem. After obtaining a balance of 19 kilograms, we added that to the 66 kilograms of allantoic fluid lost after abortion began. This gave us a final volume of 85 liters of allantoic fluid. With a range of 4 to 15 liters of allantoic fluid in normal pregnancies at term, one can appreciate the abnormally high volume of allantoic fluid in this pregnancy at only 7 months. The appearance of the placentomes was particularly intriguing because, as shown here, contrary to our findings on ultrasonography, there was a large variation in their size, with diameters in the range of half a centimeter to more than 11 centimeters. Here is the fetus itself, presumably meconium stained because of intrauterine respiratory distress. This was a heifer calf in posterior presentation. Her crown rump measurement was approximately 76 centimeters. And although this was quite large, it was only just outside the normal range for a pregnancy of this duration. Not surprisingly, the calf was extremely heavy, at 56 kilograms, far beyond the normal range of 8 to 18 kilograms for a normal calf at 7 months of gestation. The weight of the fetus appeared to be mainly due to accumulation of massive amounts of edema and free fluid. Here one can appreciate the pitting subcutaneous edema that was typical across the fetus. As shown at upper left, there was substantial subcutaneous edema in the abdominal region, and at lower right one can see a stream of fluid being released from the peritoneal cavity. The pleural cavity also contained a large amount of fluid. It was obvious that the extremely echogenic liver we had seen on ultrasonography had developed in a state of chronic passive congestion, probably as a result of heart failure. It was probably also due to poor venous return that fluid had accumulated in both the pleural and peritoneal cavities. This image shows the fetal heart, which subjectively appeared to have a slightly enlarged left atrium. However, the left ventricle showed no obvious hypertrophy. Interestingly, myocardial hypertrophy has been described in similar cases of hydrops, possibly because of resistance to blood flow in the face of severe tissue edema. This case had features of both Hydrops amnion and Hydrops allantois, a situation that has been described elsewhere. In fact, it's tempting to suggest that the two may coexist more frequently than is generally recognized because of the difficulty of measuring the volume in the two compartments. Although the inciting causes of hydrops are not clear, they seem to be associated with chromosomal mutations that arise when embryos are cultured in vitro. There's been much speculation as to the nature of these mutations, and still very little is known about this problem. These abnormalities start to manifest themselves very early on, even before the embryos have been transferred into recipients, and they continue to cause problems in a multitude of organs as pregnancy progresses. In this case, it may be accurate to suggest that malfunctioning of the kidneys led to retention of sodium and phosphorus, which in turn resulted in fluid accumulation in both the amnion and allantois. It may also be possible that those ionic imbalances, together with increased peripheral blood vascular resistance and poor oxygen diffusion into the placenta, cause fetal heart failure and the demise of the fetus. Interestingly, in human IVF, where embryos are cultured for very short periods of time, the incidence of abnormal pregnancies is lower than that in domestic animals. Thank you.